Well, hello, everyone. Thanks so much for joining us for Leveling Up on Treating Dry Eye Disease, Part 2. My name is Justin Schweitzer, and I'm an optometrist at Vance Thompson Vision in Sioux Falls, South Dakota. We focus on cataract, cornea, refractive, and glaucoma surgery. And I am really excited to be joined by Kendall Donaldson today. These are my disclosures. Kendall, let you introduce yourself.
Hi, Justin. It's a privilege to be here with you, and I look forward to hanging out and talking about some dry eye cases this evening. So, my name is Kendall Donaldson. I'm a professor of clinical ophthalmology at the Bascom Palmer Eye Institute in Miami, Florida, where I practice cornea, cataract, and refractive surgery. And here are my financial disclosures. And I'm excited to be here tonight. So, thank you.
Looking forward to it, definitely. So this is an educational activity that is provided by Mededicus, supported through an educational grant from Bausch and Lomb. So thank you to them. A little bit about CME information. They are accredited Mededicuses. You are able to get some credit this evening with the conversation that we're going to have. And you can also get COPE accreditation if you'd like that as well, a half credit for optometrists that are tuning in to join us this evening as well. The learning objectives, you can see those here. We're going to incorporate some diagnostic strategies to target treatment of dry eye disease, review some clinical evidence around treatments for dry eye disease, and we're going to talk about the design of evidence-based treatment plans for patients with dry eye disease as well. This is an educational activity, and we may include some discussion of some unlabeled or investigational use of drugs or devices. Please refer to the official prescribing information for each drug or device discussed in this activity if we happen to talk a little bit about that around the indications and warnings of those particular ones. With that said, I'm going to jump right in to this particular case. And this is my case, a patient that I see consistently these types of patients that have undergone cataract surgery are going to undergo cataract surgery very much like you, I'm sure, Kendall. And there's a lot of highs and lows with high-tech implants. I love the technologies we have to help patients reduce their dependence on spectacle lenses and contact lenses. But we got to make sure that they're being put in the right eye. And this is a case of a patient that I think it was put in the right eye, but they started to have some issues after the fact. And the ocular surface had a lot to be the part of the problem with it. So this patient had had cataract surgery. They had an advanced implant put in their eye. They came back to our clinic unhappy with their vision. And you can see their comment there after spending a lot of money on these fancy implants. So 77-year-old female, declined visual acuity, sent surgery, seemed to be constant and consistent throughout the day. She denied some of the other symptom or things like smoking, ceiling fans that I ask about in patients with dry eye. You can see medical history there as well. Pretty much everything else is unremarkable besides having cataract surgery, again, with an advanced implant. Here's examination. You can first see the structure of the meibomian glands, which are not perfect over there with meibography. Speed score, 9 out of 28. Usually if I have a patient that's 6 or above, my technicians know that they're going to go ahead and get some point of care testing, and they're going to get an MMP9 test, which is positive, and they're going to get an osmolarity test, which was just barely abnormal here, pretty close to being normal. Actually, it was normal because 308 equal to 308 or above would be abnormal, or a difference of 8. So I was doing the math wrong in my head. So it was actually a normal osmolarity test for this particular patient. Vision was 20/25 in both eyes. If you look at the slit lamp exam, some conjunctival injection, the tears and the meibum were turbid, thick when I was pressing on the glands. Tear breakup time less than 5 seconds. The implant looked good with some early posterior capsular opacification. And so my thought process on this patient was there's plenty going on with the ocular surface. We have meibomian gland problems here. We have likely inflammation based on MMP9 and some injection. Osmolarity was normal, tear breakup time low, but we also have some posterior capsular opacification, which could be contributing to that 20/25 vision as well. And so there's been a lot of studies looking at dry eye in our in our cataract patient population. And so question one, really looking at what percentage of patients had positive central corneal staining in a study called the PHACO study, or prospective health assessment of cataract patients ocular surface study. And so, Kendall, before answering this, I guess, what would you say, like, what's your experience with the amount of patients that come in with, staining that are going to undergo cataract surgery? What would have been, what would be your guess?
Honestly, yeah, over the last decade, we've really been looking at this more closely. And I feel like most of my patients do have some corneal staining as they prepare for cataract surgery. And I love the way you approach your patient. We really have to pay attention to the ocular surface, and it helps us choose our lens choice. But making that diagnosis before surgery, explaining that diagnosis to the patient, and letting them know this is the treatment that we're starting before surgery to prep them, and they'll need to continue that post-operatively. If we miss that preoperative diagnosis, then they think the cataract surgery caused the problem. And of course, as you mentioned, that's really frustrating. When they spend the extra money, they're expecting perfection. And, so we really have to make the diagnosis and start the treatment before to get the best results.
And that's this patient, right? She's frustrated because on the front end, it wasn't addressed as aggressively as it probably could have been. And I agree with you. I think the percentage is really high in this particular, study. It was about 50%. We're talking central corneal staining, but like you, I feel like
But
that's
higher
pretty
than that,
high.
honestly, in real life, don't you?
I agree. Yeah, I think it's higher than that. I completely agree with you. You said almost all of them, and I don't disagree at all. I feel like every day I do a cataract workup, there's likely, if I stain, there's some staining there, and I have to address or at least talk to the patient about it.
Yeah, I actually have pre-populated my cataract surgery prep package that I give to patients. So they're all taking the artificial tears, even if we're not, making a diagnosis of dry eye, they're all prepping, treating them like a dry eye patient because it really optimizes our outcomes.
I love that. So you're essentially 100% treating all your patients. It may not be
Yeah,
immunomodulators, but
some
you're getting
artificial
artificial
tears.
tears.
Yeah,
Yeah,
getting them in the habit. Mhm.
that's great. So the way that I intervened with this patient, we did a in-office therapy, some thermal pulsation due to the meibomian gland dysfunction. All my patients that I do an in-office procedure, IPL thermal pulsation, heat and expression, they're going to get a steroid. So this patient got, topical corticosteroid for a couple of weeks. Sent them home with a moist heat mask to do some at-home therapy. Hopefully they'll be compliant with it. Not always, but hopefully. And then possibly the YAG. If the vision did not improve with my therapeutic treatment for the ocular surface disease, I would definitely consider doing a YAG capsulotomy. But I want to wait on doing that because if my dry treatment doesn't necessarily work, or excuse me, they continue to struggle, I always want to leave in our back pocket the option for my surgeon to be able to do a lens exchange. So I don't jump to recommending a YAG capsulotomy. First, treat the ocular surface, the easy thing first. It's difficult to treat, but the easiest thing that I can retreat from first. If we recommend a YAG and that gets done, it's much harder to retreat from that. So this was kind of the intervention or treatment that I did. We know there's good data around thermal pulsation. This is just looking a little bit around some of the studies on it and the safety of it. Great percentage improvement in meibomian gland function at really a month. I tell all my patients that after we do the treatment, we got to give it a month to 6 weeks for improvement. And a lot of times I'll see improvement even out to 3 months with a lot of these patients after doing these in-office therapies. So this was my patient after this treatment. Their vision seemed a lot better. Their eyes felt better. So that always feels good before even getting behind the slit lamp to take a look. Visual acuity improved to 20/20. MMP9 happened to be negative. Osmolarity was still normal. And then when we look at the slit lamp exam, everything else looking really, really good here. Tear breakup time had improved significantly. And so we held off on doing a YAG with the implant as this patient was 20/20. We didn't see a reason to go ahead and move forward with a YAG capsulotomy for this patient. So when do we consider meibography? Ken, I was going to ask you this question. Do you do meibography on every patient, or is it kind of sporadically, or do you ever do it?
Yeah, I do it quite frequently, but I don't do it routinely on every patient. But if they really have a lot of meibum or really inspissated glands, I do meibomography. I don't really have time. It would weigh down my clinic if I were to do it on every pre-op patient. So, I would love to have it on everyone. It just wouldn't be efficient in my clinic flow. But it really gives us important information. I mean, we can see the gland drop out, all these things we would miss if we didn't have meibomography. So, I think it does give us a lot of important information.
Yeah, I'm exactly the same way. I do not get it on every single patient. It's a flow issue more than anything. I do get those point of care tests I talked about earlier, and with MMP9 and osmolarity, but this is kind of case by case. I use it a ton for education because I think it's a good way to show the patient that they have a disease problem going on. And then I think another thing we should mention is, Demodex blepharitis. It's something that we have to look for. I think in cataract patients, we're going to look at some data. It's over 50% of our patients that present for cataract surgery have some sort of Demodex blepharitis. And the reason we need to talk about it too is in the past, it was hard to treat. We would do lid scrubs and we would do maybe some microblepharal exfoliation where we try to remove it. We would do some different types of sprays on the lids to try to get rid of it. We would do our best and it would work okay. But what's exciting is we now have some treatment around that. This question here, according to a 2022 study published in Clinical Ophthalmology, and I gave you the answer if you were listening very closely, what was the prevalence of Demodex blepharitis in patients presenting for cataract surgery? And we'll see that in the data here in a second, right here. We look at Demodex blepharitis determined by collarettes in a variety of different scenarios. Cataract patients, which is the second bar over, dry eye disease, glaucoma patients, it's highly prevalent as well. So it really affects any type of patient, a contact lens patient. And again, a lot of these being over 50% of our patients that come into our clinic. And would you agree with this data as well, Kendall? Do you see this a
Yeah.
lot in your practice?
Yes, I do, Justin. I love this slide because it really indicates how, it's in all of our patients, all the different types of patients that we see in our clinic. And it's more than half of our patients, and we just weren't looking for it. So, now, as you mentioned, we have a good way to treat it. We know how to have the patient look down. So they have to look down, and you can really evaluate that upper lid and see, that crusting and the collarettes there much easier. So I think we're doing a better job diagnosing it. Now we have the lotilaner, which can help us treat these patients really effectively. And I know you're going to talk about that briefly here.
Yeah, and this is what you were just mentioning, looking at that complete colorette cure with lotilaner. It's exciting to have this. You mentioned, the awareness it's raised around looking for Demodex blepharitis. I mean, I was probably at as much fault as anyone where I'd look for it sometimes. I wouldn't look for it all the time. Sometimes I would, sometimes I wouldn't. And now it's really every patient. And that really goes to the point of what you said, that it's raised awareness around this. It's exciting to have something. And when you look at the data around this, by day 43, we're looking at complete colorette here. That means completely gone. And 44% of the patients in Saturn 1 had complete colorette cure. Wouldn't expect to see 100%. Not an easy thing to do. I mean, to even have close to 50% is very, very impressive. And you see in Saturn 2 as well, by day 43, over 50% had complete colorette cure. So the data, very impressive around this particular medication. It's dosed twice a day for 6 weeks to manage these particular patients. And then the low rates of issues with it. It's very well tolerated. You can see that about 8% of patients with some installation site pain, not really any patients significantly with vision reduction. There was one in the studies, and then about 3 patients with some dry eye symptoms as well. So an exciting medication to have in our arsenal to manage our patients that are coming in for advanced implant cataract surgery.
Yeah, I absolutely agree, Justin. Those are some great points, and that is an exciting new tool we have for our patients. It was interesting. I don't know what type of lens your patient had there in your case. That was a great case, but I really do find that some of my multifocal patients or the EDOF patients are really sensitive to the ocular surface issues. Much more sensitive than a standard monofocal lens. And maybe that's just because they're paying more. But I think the optics of those lenses being more complex really require almost a pristine ocular surface. So that was a great case illustrating just that. So thanks for sharing that.
Thank you.
All right. So I'm going to share a case of rosacea blepharoconjunctivitis, an intractable MGD. So this is a case of a 78-year-old man with concerns of just chronic irritation, lid redness, and burning. He spends a lot of time in the sun. He's a chronic golfer, doesn't like to wear his sunglasses, hat, or anything like that. So his ocular history includes a history of LASIK surgery 20 years ago. Then he underwent cataract surgery bilaterally in 2017 and for monovision, and ocular hypertension for about 10 years. So his medications included timolol twice a day, some artificial tears, and he had been on oral doxycycline off and on for rosacea. So on exam, we could see his vision wasn't too bad. Actually, it was pretty good. 20/40, he pinholed to 20/25, and in the left eye, he was 20/25, pinholed to 20/20. His pressures were on the high side of normal. His tear breakup time was depressed a bit. His Schirmer was a bit low. And we could see here a picture of his eyelashes and lids. We see some inspissated glands. He had a lot of telangiectasias along the lid margin, which he also had on his cheeks and over his nose, consistent with the rosacea there. Foamy secretions on mild uh, compression of the lid margin. And he also had some conjunctival chalasis, which I find is very, very common in these patients as well. He had 2+ punctate epithelial erosions on his LASIK flap in the right eye and a little less in the left eye, but quite similar. His OSDI, you could see he was had moderately severe symptoms. And here's a picture of his right eye. You can see that just diffuse punctate epitheliopathy on the LASIK flap. And you can see those inspissated glands with a lot of just foamy secretions on the lid margin. And we could see some mild dropout here, but very dilated full glands that, as Justin was talking about with his patient earlier as well. So you can see as well here on his LASIK flap, you can see some hot spots, areas of elevation, depression, irregularities there, really consistent with his ocular surface diagnosis, ocular surface disease diagnosis. So here's a question. All of the following are potential treatment options for rosacea keratitis or blepharoconjunctivitis, also in that category, except.
A
So
lot of good ones on there.
yeah, so there
I would
are.
just say the long-term high-dose steroids make me nervous.
Yeah,
Uh,
especially in a patient with ocular hypertension. So he's had this history. So probably not the best option there. But honestly, we had used all of these things in this patient. So,
mhm.
and a lot of times we do need different modalities for patients. And I never like to start two at the same time so you can really figure out which one is the most effective for a patient. But I think, staggering the start date of these different things, and sometimes they can just work together, but you can really differentiate the response to each of these. And again, the newest treatment that we have here, the perfluorohexyloctane, is really adding to the regimen for these patients, especially patients like this one with evaporative dry eye disease. So here's what we did. So he had been on lifitegrast for quite some time, honestly, and he also had been on loteprednol once a day for quite some time. We recently added the perfluorohexyloctane 4 times a day and tried to get him to increase his preservative-free artificial tears to every 2 to 3 hours. And then lid hygiene. He had been particularly non-compliant with some of these things along the way. And then eventually we moved on to thermal pulsation. And finally, I had really significant success with intense pulse light therapy, which he has had several treatments at this point. So, as far as the perfluorohexyloctane, here's a little bit of information regarding both these signs and symptom improvements in patients. So you can see here the central fluorescein staining at week 8 dramatically improved in both the Gobi and Mojave trials. And we can also see patients' symptoms also improved by week 8. So it met both the sign and symptom endpoints. Also for the perfluorohexyloctane, we can see that it works much faster than the average drops that we use for dry eye symptoms and signs, which oftentimes can take 2 to 3 months to take effect. There were improvements really by day 15 and 2 times greater improvement at day 57 compared to control. So much more rapid than some of the other medications that we do use to treat our dry eye disease. Do you find in your experience so far, Justin, are you seeing a very rapid response to this in your practice?
Yeah, I think, some of the sweet spots that I've really enjoyed it from that rapid response standpoints are our patients that are undergoing refractive surgery. Some of my patients that are having LASIK PRK, getting them on a bottle of this and utilizing it 4 times a day has been really, really nice. I feel like I'm hopefully, getting them to a spot that's a little quicker from the healing standpoint. And so, yeah, been very happy with that in that regard. And obviously anything evaporative dry eye, it at least comes to mind.
Great point. And I think with compliance, some of the medications that we have take 2 to 3 months to take effect. Compliance is tough when the patient's still struggling during that time period. So that's a really nice aspect of this medication. And then IPL is something I really do a lot of. It's very, very effective. It's actually been used in ophthalmology since about 2005, and we've been using it in our practice for about 10 years now. But so the area loss of the meibomian glands, it actually improves. We know that the meibomian gland score can improve. The actual structure of the acini of the glands themselves can actually improve. The eyelid appearance can improve. Those telangiectasias along the lid margin resolve. It also can decrease Demodex, actually. We know we talked about that a little bit earlier, but Demodex can be decreased with IPL as well. So it can certainly help improve dry eye signs associated with meibomian gland disease. And so this is the patient's response. I'm going to share a little video of his response after his IPL treatment. Okay, so now we've been doing the IPL treatments for your dry eye and for your rosacea for about 6 months now. I was wondering if you could tell us a little bit about your perspective on IPL and how it's helped you or changed your experience with your eye symptoms.
Well, to be honest with you, we always take a look at new procedures, and I was concerned about how this would work. And to be honest with you, I think it's been probably more than I expected in two different areas. One, I think it's helped me with my skin and rosacea, as you call it. But it also, I think at the same time, has given me a much more understanding of my dry eye problem, and that it has really helped my dry eye. I find it to be very effective in that area.
So I was wondering if you could tell me which treatments you've tried prior to IPL and how IPL compares to some of the things that you tried for your dry eye in the past.
Well, we've tried everything. I mean, from Lipoflow to Restasis and the different drops and stuff. And really, I didn't see as much as significant change in my dry eye problem as I do with the new procedure that you're doing for me.
Great. So he was very pleased after his IPL treatment, and he continued all of his topical treatments and his oral doxycycline. I also find recently I've been using azithromycin for patients instead of the doxycycline. I've been using some oral azithromycin, which has been very effective as well. So question 4, which of the following are appropriate treatments for ocular rosacea? I think, as we discussed with this last patient, fortunately, we have so many different options that can help our patients these days. We're really fortunate. And sometimes in these very challenging patients, we need multiple different modalities that can work together and complement each other to get the very best response for the patient and get them the most relief and back to normal life. How do you have patients like this, Justin, that you really struggle? You just really have to pull out kind of everything to put together to get them some relief from these symptoms.
Yeah, I mean, these are the patients, right? The ocular rosacea patients that you're describing here. There's so many, multifactorial things going on that you're going to have to do that. I did have a question for you. I'd be curious. So what is your normal traditional, IPL treatment? Is it 4 treatments? Do you do 8 treatments? I saw you did 8 on him. Is that normal for you? I'd love to know that.
Yeah, we actually do them in packs of 4. I really encourage them not to do just one IPL treatment. So I counsel against that because I tell them, it's really the additive response after 3 or 4 treatments. So he actually had 2 sets of treatments. That's how it added up to be 8.
Thank you.
And then a lot of times we'll take a break and they might come back a year later and repeat the IPL. So it's something that, really can be effective long-term, but it does take 3 or 4 treatments to get a good response. Okay. So thank you all for being with us today. And I hope you learned something from our cases. It was certainly fun. And I certainly learned from your cases, Justin. So thank you so much for sharing. And to claim your CME credits, please complete the post-test evaluation. And if you haven't watched our first part of our series, please join us for that as well. So it was great, Justin. Thanks for hanging out with me and talking about these cases and exciting new, treatments that we have for these challenging patients.
Thank you. I would do it again in a second. I appreciate it. Learned a lot. Thank you.